Not invited to that reception.
So the interesting part is it's actually a real idea.
Thanks for coming to our session. Yeah. No. You're flying to Nairobi.
So good morning, everyone. As people are trickling in, I thought we should start, bearing in mind the issue of time. So I would like to welcome you all to this session on more informative clinical trials, the DAC Africa story. So from the Africa office of EDCTP, this is a new initiative that we value so much, and we are working very closely with our colleagues from the foundation for the reasons that will be contained in the presentations that you'll hear. But in a nutshell, for an organization like ours that is bound to produce clinical research of the highest quality to international standards, we are really honored to have DAC, and especially DAC Africa. The natural situation is that if you are in a supported organization or institute, and you're a student or a postdoc or somebody, your research idea or protocol is more likely to go through very senior scientists within the institution, and they will panel beat it the way that before you submit it to anybody, including funders, it has been enriched and it looks good. At the funding level, where I've been for some time, there isn't much time for scientific input. What the reviewers do is just look at what you have put on paper and decide if it has good quality enough to get some funding. And then funding is allocated and you're sent into the field to do the work. And we have seen so many times the study has already started and people are saying, nah, this is not what we really planned that the study should really achieve. Then you say, so what do we do in this case? Oh, they just continue. And at that point, it has gone through ethics review, regulatory review, and you start asking questions. After all these gatekeeping barriers, how did this happen? It's only now I understand through DAC that this is not just a one-stop process. Science evolves from the generation of an idea to implementing it and even after. And that it requires a lot of input from different minds and different circles. That situation is typical to a good institute, and I can give examples of those around Africa that I know they follow this kind of process. But scattered around in a continent like Africa are poorly supported institutes and scientists still struggling, writing proposals and research ideas from the bedroom, hoping that they are going to squeeze it before the submit button disappears on a funder's platform, and then it's going to be an idea that somebody's going to buy. Okay, if it gets squeezed in, then again the quality issue starts to creep in, and then the issue of uninformativeness starts to appear. And I think this appeared more, as you hear, during COVID time, when we were all doing these things in a rush. It's the same scientists, with the same knowledge, wisdom, very well placed in science, but they were just, something just changed, that haste became a factor. And we wasted billions and billions of dollars that the trials that came out of it, 95% of them don't tell us what they were designed to do. And so such a wastage should never be repeated. And we can only do that if we embrace a program like what you're going to hear today. Now, every program, when it comes, is about mindset change, which can be very difficult when people are used to their old ways. The questions we should be asking is how then we can embrace such a program into our programs. And I think those are some of the things that may come up during the discussion on how we make such a program part and parcel of what we are doing or what we are planning in around the world. And for us as EDCTP, because the battleground is Africa, what do we do in Africa? How do we make it something that really benefits the process? And the process, as we discussed in this forum, starting from how we train people from colleges, how they go into research, and how they practice that research and benefit that research. So it's a pleasure for me to welcome the first speaker, who is Thea Norman, who I've known for some time through Avaref, and now we're working together in this endeavor. The floor is yours, Thea. Thanks.
Okay, can you hear me? Yeah, you can. Good morning. It's the champions who make it out on a Friday morning at the end of a long week. So congratulations to all of you. You made it here. I hope it will make it worth your time. I want to thank Tom for the kind words and the meeting organizers for the chance to share about DAC and, more importantly, about DAC Africa with all of you. This is an important meeting, and we appreciate the chance to be here. So I'm going to talk about informativeness in clinical trials as prologue to the main event of introducing you to the DAC Africa team. So in clinical trials, but also in global health trials, as Tom talked about, they fail often. And when they do so, they provide uninformative results. And many of the key drivers of failure can only be changed during the design phase of trial planning. And so some definitions are in order. Uninformative is just what it sounds like, a waste of everybody's time. It means results that don't allow anybody to take a decision or to make a next step, and it's a huge compromise of trust, money, and time. Informativeness is something we're all seeking in clinical trials, and this is a robust clinical insight that allows confident decision-making, so decisions about the next phase of development, a policy change, these kinds of choices. And as Tom also prologued, uninformative trials happen frequently. This is a stark example from COVID-19 put out by the FDA. Looking at those first months of COVID-19 and all of the trials that were getting started so quickly and asking a simple question: how many of those trial arms were randomized and adequately powered? And if you look at this chart, the sad news is it's only the slivers, the blue slivers on the top of each of the gray bars that are meeting that mark. And so in fact, this is the reason why so many of those trials were basically a failure before they even got started, because of these decisions that happened so early. Another example from the global north was published in 2022. This is 125 randomized controlled trials in well-known diseases, and asking the simple question, how many of these are completing informatively based on 4 definitions used in this paper. And on average, only 26% of these trials check that box. 50% of trials run by industry in this paper are ending informatively, and sadly, private and government-funded trials fared much worse. Only 6% of those trials are ending in an informative way. And when you think about the work in global health, the diseases are less well characterized. Where the studies run is a much more complicated setting than the research centers in the United States. And so at the Gates Foundation back in 2019, sitting with this as the reality, there was a paper published in JAMA with a really compelling quote in it, at least for us. It said, funders have a responsibility to ensure that the trials they fund are likely to be informative. And this was really a call to action for us at the Gates Foundation. And the Design, Analyze, Communicate program that I lead was really the answer to that. And we've been focusing over the last 4 years on supporting our grantees to every extent possible to support improved study design so that more of the investments at the foundation can have an informative outcome and have that impact that we all are seeking. And so our vision is one of informative clinical research, and this is a cartoon of a dartboard. And on the left side is the current state where, as I told you, about 30% of trials are ending informatively or being planned that way. And so an example is incorrect sample size, so the trial is underpowered and it never is able to finish. That's a poor choice for planning. Or putting the trial at a site of convenience rather than where the burden of disease exists, and so then a trial can never finish. So we want to move from that current state to the picture on the right with all of the arrows in the middle at the target, which is all the choices that are being made during trial planning are ones that are going to optimize the study for an informative outcome. So that's what we've been seeking in the work we've been doing. And at the Gates Foundation, I lead a team called the DAC team, and we exist to improve the informativeness of global health clinical studies, and we do this by performing scientific design reviews, and I'll tell you about that. We also fund trial planning grants, and we innovate and develop informativeness tools and resources that we use and that we share. And so our acronym, DAC, is designed to remind our grantees of the 3 critical areas of study planning that affect overall informativeness. Design is the big category. It's the one about asking the right research question, making sure to use standardized endpoints when they're available, and having access to clinical trial simulation tools so that we can evaluate designs to find the most informative and efficient design to go after. Analysis is to remind our grantees how important it is to draft a statistical analysis plan before the study starts so that the data set, the evidence being generated, is clear, and we can all make sure that we're answering the right research question with that data. And finally, communication, how important it is to engage stakeholders before, during, and after a study. In the policy space, as funders, we want to make sure that if we generate evidence, we fund a clinical trial, is that the evidence that policymakers need to make a decision? So this communication is fundamental. Inside the foundation in 2023, the services that we offer to our disease area teams are here. We really do 2 things. We do reviews, and we fund trial planning grants. We have 2 types of reviews that impact clinical trial investments, and these are the dark blue boxes. So we do an advisory review. This is engaging at a very early point in a grantee's planning where they might have a study synopsis or a draft grant. And our DAC teams provide feedback really at a strategic level at that early point on what are the different options that could be considered. And that feedback helps our grantees go into that protocol drafting phase with opportunities to incorporate those kinds of suggestions. Our protocol review is exactly what it sounds like. This is looking at that full detailed study protocol. That often happens at the first stage in a grant from the foundation, but it can also happen for studies that are in flight where trouble has happened and brainstorming is needed to solve problems. We also fund trial planning grants. This money goes to PI teams who need augmentation of technical expertise to support them during study planning. So if a team is trying to develop a complicated trial, maybe adaptive trial, and they don't have that kind of expertise on their team, these trial planning grants are designed to bring in experts that they can partner with as they're developing their plans. Our reviewers in 2023, the kinds of reviewers we have are listed on this slide. At this point in time, our team funds 70 clinical trial experts who are not inside the foundation, so they're independent and separate, and we organize them into review teams to conduct the reviews. And so for every review team that we include, they have the expertise shown in the light blue boxes on the top, so 4 individuals with those areas of background, and then depending upon the specific study that we are looking at, we add in subject matter experts with additional topics. And so at this point in time, based on the demand and interest inside the foundation, we have 3 review teams that we can run at any one point in time. And this is to address the growing demand inside the foundation for the scientific design reviews we offer. So our DAC reviews are not required inside the foundation. We're available as a service to our disease area teams. So we get asked by our disease area team partners come and help us with this review and our grantee. And so you can see over the last several years, the growth of these reviews has grown quickly. The colored boxes are the different disease area teams inside the foundation that we've been working with. This year, we're on track to complete 60 reviews. So the demand continues to grow for this work inside the foundation. The other thing we've looked at is what have we been saying to grantees over the course of the last couple of years. So we stopped and looked. So this is a summary of the 700 and change recommendations that were made for 52 protocol reviews done over 2 years. And these recommendations are the highest criticality ones that we offer. These recommendations are around issues that we believe, if not addressed, would put the study at risk of ending uninformatively. And so what you can see is that, not surprisingly, it's the most technically challenging parts of a study plan that are the ones that we are most frequently commenting on and trying to help with. We see on average through our reviews, at least at this point, that about 13 recommendations were being made per review. We also see that nearly all of the time PIs are choosing to implement the DAC feedback, and really this is the most significant form of impact, is to see grantees choosing to take up some of this feedback to improve their protocols as they go forward. Along the way of our work, we've been creating tools that we've been making available on our public website to share with others. And so I encourage you to check out the DAC website. We have our best practices for informative research video library there that explains the different best practices and why they are so important for trial planning. We also have funded the creation of open source clinical trial simulation tools for biostatisticians to learn how to design adaptive trials as well as cluster randomized trials. There's much more there, but those are a couple of examples. And before introducing the DAC Africa team, I'll just touch on some of the partnerships that the DAC team has developed over the last 4 years to socialize the challenges of designing informative trials, and also to offer tools and resources to partners who are working in the same space. And we've had a fabulous collaboration with Tom and his team over the last year, looking to share out this information with the clinical trial networks that EDCTP manages. We also have had a long-standing collaboration with African regulators through our commitments to AVRF since 2020. And my last slide is to introduce DAC Africa. So this is a recently launched resource from our team to build capacity for DAC reviews on the African continent. So I'm going to end there and introduce Yauba. Come on up.
Thank you very much, Thea. I think it's usually a very difficult task to talk after Thea, but I'm actually going to do my best. So I think this is the title of my presentation, and when you look at it, you see that it's somehow different from the title that is contained in the booklet, and I think there is a reason for that. I think they said if we want to get people up at 7 a.m. to come and listen to this talk, we need to tell a story, because as you heard from Tom, Africans are good storytellers, and most of the times our stories are actually inspired by bravery, courage, and also hope. But at the same time, they also have a number of the kind of point to a looming danger. And what is a looming danger that we are talking about? Thea alluded to it, the problem of informative clinical trials in the African, globally, and more specifically in the African continent. So if we step back like 20 years ago, when EDCTP was founded, Africa had about 0.9 million, with almost the same statistics with respect to the proportion of world population and also disease burden. And this is where we are in 2020, 20 years later, in 2023, with these dynamics. And the projections actually indicate that in the next 20 years, Africa will be a continent of about 2.5 billion and will actually account for about 25% of the world's population and also about 30 to 40% of the world's disease burden, which is a problem. And logically, it is right to say that the number of clinical trials are going to increase in the African continent. But there is also the risk because already with the 2.5% trials that are happening in the continent currently, a significant proportion of them end up uninformatively, as Tia pointed. And what we know is that uninformative trials, as Tia mentioned, actually depicts waste of time, energy, and scarce resources, and more importantly, is a discouragement for return on investment and do not impact global public health. So that is one of the things that we want to change. And that is a problem that we want to address from the root. And that is where DAC-Africa comes in. And really, our mission is to promote clinical trial informativeness within the African continent by establishing a network of African-based experts who are well-grounded in the science of clinical trials within the continent. So we heard from Professor Jimde the other day that in Africa it takes a village to grow a child, but I think when it comes to clinical trial in Africa, it actually takes a nation to successfully implement the trials, from custom approving the importation of medicinal products, dealing with side effects, dealing with political hurdles, and so on and so forth. And these are some of the things that many sponsors and PIs are not often aware of, and these are things that if they are not integrated into the protocol at the embryonic stage, many trials are really might end up facing significant challenges when it comes to recruitment and also when it comes to addressing the questions that they were designed to address. So in terms of objectives, we have about 3 principal objectives. One is to review the clinical trial protocols, provide sponsors with the opportunity, as Tom was saying, to actually critically look at the protocols, look at all of the elements that are necessary to make a clinical trial informative. And the second is to provide African PIs with all the necessary tools, that innovative tools, clinical trial tools that they mentioned, so that they can use them to actually improve on the design and the development of their protocols, as well as the different best practices that can actually provide some sort of signal or assurance that their trials are likely to end up informatively if all of these concepts are embedded into or integrated into their clinical trial protocols. And then the last objective, which is actually an objective that is actually dear to many people, particularly the sponsors, is to create an enabling environment for clinical trials in Africa. So Thea has already mentioned the work they have done with NAFDAC. So one of the things we want to actually do, starting with Cameroon, is to digitize the ethical review process so that PIs or sponsors can actually submit their protocols electronically and reviews can actually happen electronically. And we think that by doing so, we are gonna reduce the approval timelines. So let me just stop here and then hand over to the Pope of the Science of DAC-Africa to correct the catechies.
Thank you very much, Dr. Yawa, and it's a pleasure once again to be here on stage after 2 incredible speakers. I'm here to just talk about what DAC-Africa does, essentially. So what are the services that we provide at DAC-Africa? It might seem like a repetition of what they are mentioned, but here there will be some specifics, adaptation into our own realities. So DAC-Africa helps principal investigators and funders to maximize their return on investment, and we do this by providing protocol review services. If you can go out of this hall with one thing that you want to remember about DAC, it's about protocol review services. And so we do this by really bringing together a panel of really well-grounded experts across the continents from different fields that matter when it comes to the design of a protocol. We have those experts in the area of quantitative research, biostatistics, and those who are very versed with regulatory issues, those who are also versed with conducting clinical trials in LMICs. And these review services happens first by when we received a call for a protocol, we have an alignment meeting with the principal investigator. Then we are able to really explain to them how lengthy this protocol review service will take place, usually between 5 to maximum 6 weeks in terms of turnaround time. So when the review is over, we kind of provide technical feedback to the principal investigator in a very subtle manner that makes them see that we are here to help, not to instruct, not to step on the egos, but to say, this is just how we think. If you improve your protocol, it can end up informatively. And the second thing we do at DAC Africa is similar to what Thea mentioned. At times when we are reviewing a protocol, we might notice some gaps, or maybe that the research team lacks capacity, maybe in terms of hiring somebody as a biostatistician to help them with their statistical analysis plan. So this is an opportunity for us to issue a trial planning grant. It might not be as big as a trial planning grant that is issued at the gates, but at the level of Africa, we try to make it a little bit significant, from $25,000 to $30,000. That can actually help the research team to kind of work on improved on their design. So what kind of protocols do we review at DAC Africa? We review phase 1 to phase 4 clinical trial protocols. We also review interventional and implementation research protocols, and even health technology assessment tools, technology protocols. We also have expertise that can provide this kind of review. And we keep updating our team of subject matter experts drawn across the continent based on the demand that we will be receiving from funders and PIs on the type of protocols that they want us to review. But there are some few criteria that we've set to review protocols. The first is we want to be able to make sure that the protocol, the research will be conducted in Africa. That is why it's DAC Africa, though we have already received some protocols from other countries out of Africa. And so we also want to be sure that the protocol we are reviewing is one that already has secured funding or is at the verge of securing funding. And this is simply because we put in a lot of financial resources to pay these experts, and so we don't want to find ourselves in a situation where we review a protocol for a trial that would not be conducted, maybe because there is no funding at all. So this is just to help us make sure that there is some assurance that the trial will actually take place. And so we also want to be able to review a protocol at a time when the principal investigator and the research team still has an opportunity to make adjustments, right? Because if the protocol comes to us when you've already had all your ethical clearance and everything is fixed, you are set to go, you don't want to change anything, then the review will have no impact on the PI and the research team. So we want to be able to intervene at this early level. So we do not want to restrict our review on the type of funder, so we are open to all kinds of funded protocols and trials. So as Thea mentioned, what makes us different in our review process from other internal reviews that happen in other institutions is that we also do carry out these reviews based on some available tools and resources that also serve as a reference frame to all the subject matter experts that are participating in the review. The first is the DAC assessment tool, which Thea mentioned. Of course, when we took these tools that were developed by the Gates Foundation, we kind of adapted it to suit our own African context. And so the DAC assessment tool covers a broad number of topics, which we consider that if an investigator designs a protocol with those considerations in mind, then there are high chances that the protocol will end up informatively. And this DAC assessment tool actually is handed to the principal investigator after our alignment meeting. So if we receive your protocol and we've agreed that this protocol is going through our review, the first document you receive from us is the DAC assessment tool. It's like a questionnaire. It covers really all these thematic areas you find here. You have general issues covering issues around the question that you're trying to address, what phase of development and what decision will be made when the data is collected. And we also have design questions. Where do you choose your study sites? Is it based on disease burden? What are the endpoints? Are they validated endpoints? You ask questions about biostatistics and sample size. And on the analyze aspect, we also have questions around, statistical analysis plan, if there is one, or if there is plan to create one. And of course, issues around communication. Do you have communication plan? And of course, at the DAC Africa, we have a template for communication plan, which we can as well help investigator and say, this is how you can design a communication plan on how to communicate before, during, and after your clinical trial. So this is the first very most important tool that we share with the principal investigator after we've agreed to review the protocol. The next very important tool is the DAC best practices. These are 16 best practices, important aspects of the PI's clinical study that we think if they really consider during the planning of their trial will really lead to the informativeness of the trial. And if you look at the 16 best practices, it's designed according to the name: design, analyze, and communicate. So the first 6 best practices are covering issues around design. Did you prioritize the disease burden and epidemiology when choosing your study site? Did you think about if your endpoints are validated endpoints? And what about justifying the effects estimates and prevalence assumptions that you made? These are all issues around the design. And looking at issues around analysis, we want to ask, did you analyze real-world evidence to optimize the study investments and objective and feasibility? What about just asking questions if you were able to use model-informed drug development such as PK/PD modeling? And these are questions that we can actually provide, some guidance based on the kind of expertise that we have who are reviewing this protocol. We have really, really incredible experts that are grounded on issues on PK/PD and can really give great advice to our PIs. And you have issues on communication. We want to be able to ask, have you engaged with regulators, ethics committees, policymakers before, during, and after the study? What are your plans for this engagement? And how do you plan to communicate, or maybe around informed consents? We have really seen that communication is very important. A lot of clinical trials face challenges on the implementation side of things because there is just absence of communication plan. And we have actually developed this tool that can help principal investigators to actually design a very good communication plan. And so these are really best practices, which not only used by the subject matter experts, but one of our responsibilities in DAC Africa is to socialize these best practices across the continent so that principal investigators and researchers can have access to it and continue to use it in the planning and designing of their trials. So in order to do this work, we have actually done some work to bring together a set of really incredible experts, African scientists with demonstrated expertise in the clinical trial-related fields, as you can find on the field. And I'm really honored that one of our senior reviewers is right here, Professor Afolabi, who is here in the hall. Seated, please, with your finger up. He is one of our senior reviewers from the London School of Hygiene and Tropical Medicine. And we've really brought together incredible people to do this work: biostatisticians, those with background in epidemiology, clinical pharmacologists, and we keep growing our team as we continue to get the demand for our services. And also, we have some thought leaders, reputable thought leaders in the clinical trial space who we have put together to form our steering committee. And these are people who sit, 2 or 3 times a year to analyze our work and give us advice and tell us, how best we can do this work. And this steering committee is chaired by Rose Leke, who is one of our eminent professors and researchers in the continent, well reputable and multiple award winner in the public health space as well. So then at the end of the day, what's our value proposition at DAC Africa? I want to look at this through 3 lenses. First, through the lens of the funded PI teams. First, it is free. Is that not incredible? That all this work we do is free to the funder and the PI who submit their protocol to us. It's very expensive for us to go through one round of protocol, considering the number of experts we bring together to pay for their time. So this is really an incredible investment, and we want to thank the Gates Foundation for offering this wonderful grant for us to do this work. So it's really great for the PI to have this service, because then every PI will be happy that there is likelihood that their research question will be answered at the end of their study. But also looking at it from the side of a funder, every funder funds a clinical trial because they want to improve health outcomes, or maybe because they are seeking some regulatory approval. So there's a return on investment if a funded trial ends up informatively. If it ends up uninformative, then the money was wasted, and then you didn't have a return on investment. Looking at it through the lens of the regulators, we continue to engage with regulators and ethicists and those who are on ethics committees, and we try to socialize all the best practices and the concept of informativeness. And so this really helped them to participate in the informativeness dialogue with the PIs, as well as all the different researchers that they receive. Now, most importantly, on the side of participants, those we care most about. When a trial goes through our review, then we are sure that this trial will be informative, but then we are also sure that fewer people will be exposed to non-effective treatment. And also we can identify during our protocol review some of those elements of the review that will that maybe shows that the principal investigator or the research team is not going to leave a positive research footprint, clinical trial footprint. By this I mean, how do you leave the research community at the end of your research? Do you just pack your bag, gather your data and leave? What do you do to the community that makes them feel that you were an incredible partner and that they can also welcome the next researcher when they come? So all these are the kind of things we think when we review your protocol, we can give ideas that will make you take care of these very little things, but that matters very much on the field during clinical research. So at the end of the day, I want us to look at DAC Africa as a resource for clinical trial researchers, institutions, and sponsors on the continent. Very importantly, an African-based hub and network promoting clinical trials done by Africans for Africans. Thank you very much. And now I'll take this opportunity to invite Caxton, who will be like one of the happy customers of DAC, to tell you a little bit about the experience of going through the DAC review. Thank you very much, Caxton.
Good morning, colleagues. I'm honored today to stand here and talk about the value of the DAC engagement, specifically because we have experienced the process, but over and above that, we see a lot of value. In addition to what you just said, this service is free, but also a lot of value that we see at the Science for Africa Foundation. So I've been asked to speak about our experience as clients of DAC review process. This engagement has been with the DAC global team because of, at the time when we started engaging, we've engaged with the DAC global team since way back, I believe, in 2019. And we've seen it grow, and we're happy to see where this has reached, especially the DAC Africa team. So we managed to get support as Science for Africa Foundation in the development of 2 clinical trial protocols optimized for informative outcomes. And also, this has led to us engaging further with local experts in the continent. And the study was focused on studying infertility in Africa. So according to the WHO, 15 out of 100 people in Africa have been infertile or experienced infertility, which is a core aspect that we thought we should engage in. And having engaged in September of 2022 with the DAC global team, we were able to discuss aspects of a study that we call the GAIN study, Genetic Association of Infertility in Africa. And from the initial advisory review, which was more at the early stages, we were able to get feedback to the SFA Foundation ranging from various aspects that were very critical. So that's looking at aspects such as multi-site pilot study, data analysis strategy being formulated, the sample size, and also potential investigation of male infertility beyond the female infertility aspect that was the initial focus for this study. So we've also received the DAC trial planning grant element, basically which helps us engage technical experts in the continent. So this aspect was introduced by Thea before. For this kind of study, we wanted to ensure that we have technical experts on the table. And the initial review helped us to have this planning grant to engage the technical experts in the continent to build further on this protocol. So the building of the clinical trial protocol, statistical analysis plan, engaging in trial simulations, as well as the communications plan. And through the grant, we did have an engagement with this team earlier on in the year, and this now yielded to the actual protocol being developed. And this followed the outcomes of the initial advisory from the DAC global team. And this now took a second review process as was presented initially. So we did have an engagement further with the DAC global team just to understand from this now improved protocol? What are the aspects that need to be reviewed? So this is an ongoing process. We've received the feedback quite significantly, and it was quite rich feedback that we did receive from the global team, and that's in the process of being worked on. One of the outputs that I'll talk about that came out of this review process is extending this protocol to focus on associations of male infertility, in addition to the female infertility aspects that we had initially focused on. So in terms of what value or the key takeaways that we see from this process, first of all, I think this has been mentioned previously. There is a varied expertise from this team that is constituted within the review process, looking at various aspects of the study, endpoints of the study, as well as study outcomes. So it's quite important for us, or it was quite important for us as we engage in this initiative to reduce the risk, even as we're trying to be creative in terms of how this is being implemented. It was quite important to understand how do we reduce the risk of uninformativeness of this trial. And in verbatim, having discussed this with the team, it was important just to understand how do we break this down in very realistic aspects of delivery of the trial. So in the sense of delivery, then, it helps you understand these are the risks and this is what needs to be done from the perspective of delivery. Of course, as Thea mentioned as well, at a very early stage, it gives you a go or no-go decision. Do you want to engage in this study, and what are the aspects you need to look at? If it's a go, if it's a no-go, then there's an opportunity to get feedback on how to improve that study protocol. If it's a true go, then also it gives you the confidence to get into this study putting in mind that this is going to yield the much-needed results. Secondly, we feel that the assurances that this provides helps have a clear understanding in terms of impactful of the clinical trial that you're implementing. This was quite important for us to know that this will lead to change in policy or an intervention in that sense. So going through the process provides you with that confidence that this is something that you can achieve. We have been mentioning in previous meetings through the clinical trials community and the clinical research and trials community program that our main aim is increasing investments in the continent on clinical trials, and that has been our message for quite some time. So increasing investments also has to have the aspect of informativeness, as Thea mentioned. So we see that as a very big value in terms of engaging through this process. And then also, from a funder's perspective, it provides credibility in engaging within this initiative. And going through the DAC review process will give credibility to the study and also give confidence to the protocol that will be executed to reduce the probability of failure. So in summary, I think I'll mention that this has been a valuable process. In addition to also engaging with the DAC global team, it has been a learning process because of the engagement within this space being a new frontier for us, but then also validating that we are trying to increase investments, but in a more informative way, in the sense that most of the clinical trials in the continent will lead to a more impactful or solutions that are impactful for the African patient that we serve. Thank you so much. So I'd like to introduce Bahati for this next session. Welcome, Bahati.
Thank you very much for all the great presentations. So I'm going to ask our presenters to go to the front, and then we'll have interaction. As you've seen, DAC is truly a public good, and you've seen that it's really participatory. And I think I'm hearing all of us saying prevention is better than treatment. So we can prevent this waste. We can prevent the waste of resources and time. So this is an opportunity, because this DAC team seems like they ask questions to you. I think it's an opportunity for you also to ask questions. So let me just see, but just by show of hands, how many people have questions? Great. So if you can just go to the mic and start lining up. Oh, you have mics moving. I just want to see the hands. Okay, 1, 2, 3, 4. just introduce yourself, and if you have a particular question that you want to ask any particular presenter, please just make it clear. So let's start with the person with the mic there.
Thank you. My name is Lenia Swenda from Medicines for Africa. My question is to the speaker on the, yes. Yeah, I think, it's really great, the work that you're all doing at DAC. I think it's an excellent resource. My question is, you mentioned that you started this work with a grant. What is the plan for making it, such an important resource sustainable over the long term? I mean, how are you thinking about how you are going to take this work forward in terms of its financing? Are you thinking at some point that you would have to start charging for these services from the clients that you're serving at the moment?
Great question.
I apologize for my voice. I'm losing it.
Your voice is fantastic. I think sustainability. Elvis, before you answer, I'm going to ask to take the 4 questions just because of time, and then we're going to answer the questions. Yes. Please, can you stand and ask the question?
Yeah. So thank you for the presentation. Tom de Croo from Antwerp. I have one comment and one question. One comment, I think one of the reasons why sometimes our efforts remain without result is that by the time that the results get out, they're already outdated because guidelines have evolved. So, and I think even during the past days, we've seen some examples. Another a question I had is, okay, it's great to see this involvement in the early stage, but what about staying involved once the trial is ongoing? For instance, in a DSMB, in a Drug Safety Monitoring Board, or in a treatment monitoring group, so or a trial monitoring group. So I think this could be other ways of maybe staying involved and maybe guiding the trial throughout its
continuous engagement. Yeah, great. Let's see, third question.
Okay, thank you. I'm Suleiman from Burkina Faso. My first question is about could we expect that passing through the DAS procedure will be in the future a condition for funder to go forward with the trials? And the second one is how local expertise in a particular country where the trial was setting to be conducted were valued as it can be important for to have a point of view in the local setting, because some of the decision may be better guided by local expertise within the country.
Okay, so enforceability of DAC and local expertise. Yes, maybe the last question, and then we're going to turn to the speakers.
Thank you. Yes, I think probably a related question, and also congratulations to DAC and what a fantastic service that you're offering. I was just wondering, as Thomas mentioned, there are multiple gatekeepers in the process to getting an informative trial underway, and in your conversations with ethical reviewers and regulatory bodies, do you see a need for something similar in terms of tooling up, upskilling in that area? And I think many would argue an uninformative trial is unethical.
Did you introduce yourself?
Sorry. Apologies, I'm Rachel Hallett. I'm from the UK, from the Good Clinical Trials Collaborative.
Fantastic, thanks. I'm going to turn over to our speakers. I know some of the questions were, Elvis, I think there was one for you, but I'll turn over to all the other speakers to respond to any of the questions. Just pick one and answer in the shortest time possible so that we can have.
Yeah, thank you very much for the first question you asked about sustainability. You know, that reminded me of some software business where you download an app and it's free. And by the time you've gotten embedded and used to using that app, and then some 8 months later you want to open the app, they say you have to subscribe. And you're like, gee, what can I do? I need to use this app. And you're forced to just pay the subscription because you found the app very valuable. So sometimes that model of business of starting with free and then paid is always very good, because then you tend to see if the person really valued the service before paying for. I think for DAC Africa, we hope that our services are going to be valued by our customers, who are the PIs and the funders. And our hope is that many more funders will find the need to fund DAC Africa, right? So if funders can fund trials, and they really want to have their return on investment, then those same funders can also fund DAC Africa to provide their services. So that would be one of the ways, and this can only happen depending on how well we continue to provide these services and the kind of feedback we get from PIs and funders, and that would be our marketing strategy. But of course, we do hope that if we don't have any funding and we say you should pay, at least you'll be able to consider our services worth paying for.
Great, thank you. Thea, do you want to take any? Yeah, go ahead.
I'll maybe comment on the last question, which was about regulatory and ethics. So we have been, DAC Global has been interacting with AVRF since 2020, really asking the same question that I think you're asking is there a role for informativeness as a part of the regulatory review? And so Elvis mentioned the DAC assessment to a questionnaire. So in Nigeria and at SAPRA and also in the joint review now, there will be the inclusion of an informativeness assessment questionnaire as a part of the application process and review. And next year, one of the biggest goals that we have for our AVRF work is to create a training focused on how do regulators think about integrating informativeness into the way they do their reviews. So we're hoping that that will augment and inform regulators across the continent.
So just to add to what Thea was saying, I think one of the key things that we perhaps we need to acknowledge is that ethics and regulatory authorities have been there for a while. They have been approving trials, reviewing protocols and approving trials, but yet we still see a high number of trials ending uninformatively, which actually means that there is something that is not being done right at the level of ethics committees and regulatory authorities. So I think work has been done in Nigeria, but I think also in Cameroon, we have like one of the key focus to engage our ethics regulatory authority. Elvis also talked about the concept of socializing this concept of informativeness, particularly the 16 best practices with regulators and also ethics committees. And I think this was really like one of the key recommendation that was asked during one of the sessions that was focused on ethics and improving ethical reviews in Africa, like having some sort of scientific component or some sort of scientific group to take part to actually look at the science of the protocol before it goes through the ethics committee.
Yeah.
So I just wanted to add that.
Yeah, but as you are even answering that, very good points. Can you tell us a little bit more about that continuous engagement and how you look at engaging with a local expert from where the trial is happening?
Yeah, that was a very great question. First of all, DAC review happens at the time of the protocol design, and our hope is that at that very early stage, the protocol is well designed and captures all the things that are important for the PI and the funders to take note of before they actually get into the full implementation of the trial. What we bring at the end of our review are recommendations. And we have really no obligation, you have no obligation to make use of our recommendations, but we hope that these are recommendations that if you implement and optimize your protocol, it can lead to an informative outcome. So we really at DAC Africa cannot guarantee that we have any authority to come to your research team and check to be sure that you implemented this recommendation or you did not implement it. But we hope that if you value that these are really great recommendations that can lead to a successful research work, then you would be able to implement it. But one of the things that have happened in DAC Seattle, I'm sure Thea can speak to this, is that we also try to have a feedback on how many of our recommendations were implemented. And I think if we do this work progressively, we can be able to really see how much of the feedback that PIs are receiving from us are actually being implemented. At the level of like setting up DSMB and maybe some committees, ad hoc committees, whatever, what the team will do at the time of review is to look at your protocol and ask questions. Who are the members of your DSMB? Is there a DSMB in place? Do you think about this? So if we make sure that all those things are addressed in your protocol, then we all trust that because you have put those recommendations, you are going to actually be responsible to implement them. talking about making use of a local expert, DAC Africa for Africa, our expertise is drawn from across the continent. It will be an incredible pleasure that a study is taking place in Burkina Faso, and maybe one of our subject matter experts comes from Burkina Faso. But I think even without having a subject matter expert from Burkina Faso, we have African experts reviewing this protocol, and I think our contexts are really slightly similar in some ways that we can be able to understand what is happening in Burkina Faso and what is happening in Mali, as well as what is happening in Central Africa. So we try to make sure that we draw our subject matter experts from across the different continents.
Fantastic. I can see Thea wanting to
You
give the last comment.
Yeah, you mentioned guidelines, and that guidelines change. One of the tools you'll find on the website that we developed is called the Target Policy Profile Tool. And this is a tool to help ensure alignment of the stakeholders that are all needed to support a policy change. And so that kind of tool is a living document, like just what you said, so that when there's guidelines changing, the Target Policy Profile Tool can be a mechanism so that stakeholders who all have a reason to be involved in the conversation can meet and align on the information with policymakers to speed up the process of agreement towards a policy change. So that's something that's available on our website, and I'm happy to talk more about it after this presentation.
Thank you very much, Thea. I know we are running out of time.
There's one question that maybe there was a question about if our services at some point will become maybe a condition for providing. Yeah, I just want to think that we want you to see DAC Africa as a service. We don't want to be another layer of regulatory body before maybe things get approved, but we want to that DAC Africa should be perceived as a service, and it's up to funders to see if they would want to advise their PIs to get their protocols go through DAC Africa review.
It's a good point, Elvis. And again, I think to just turn it over to Yaoba to conclude and give us an insight on how we continue to engage with you. A tool is as good as when it's used. So, Yaoba, can you tell us before we go to the plenary, how do we move forward from here? So, turning it over to you.
Thank you very much. I think it's a very difficult task to ask the catechists to summarize what the cardinals have decided in Rome to their faithfuls. But the key message here is that we are operational. We have like a good setup, and we are available to start receiving and reviewing protocols. We have already received and reviewed the first protocols, and I think a number of protocols are in the pipeline. So that is the first takeaway. We are available and ready to work. The second takeaway is that please do consider us as a think tank. We are entrepreneurs, so we have that capacity of actually thinking and solving local problems. And there's also one last point I wanted to make. We are cognizant of the problem of inequity and injustice when it comes to distribution of clinical trials within the African continent. We had the cries of the Lusophone countries and the Francophone countries, and I think this is in the quest for justice and equity. I think we as a think tank body, I think we definitely going to look at ways of supporting those countries, either through translation of resources or helping them better develop their protocols and implement their trials. Thank you very much.
Thank you very much. Let's applaud. And the contacts are right there, so I think we have a way of engaging with you and following up with you. So thank you very much for your time on a Friday morning. So we truly appreciate this opportunity to engage with you and move forward together.